for the last. And the next speaker will be Sapna GANGAPUTRA, and she'll be talking to us about imaging biomarkers differentiating between active and inactive lesions.
How do I get mine?
No.
उस वाले पे. Thank you so much. Thank you for really to the organizers of APAO and most importantly IOST and Vishali for having me here. Thank you audience for being here to listen to this. And thank you. What I'm going to be talking about is builds up from what Dr. Thorne just said. So we started with SUN 2, and really good clinical data about how we should define diseases, classify diseases. But as she mentioned, the imaging part of that was reliant on what the physician said that there was. They didn't really do a lot of deep dive into how does imaging really help consolidate this, how do we really differentiate between active and inactive. And so then what we did was we started talking about MOVE, which is multimodal imaging in uveitis. And for this, what our goals were, overarching our goals were, is to identify diseases, and we started with diseases that had good imaging. So we started with posterior uveitis, and we're going to look at the posterior uveitis categories that we can look at multimodal imaging and build upon SUN. We did not want to recreate the wheel. We did not want to start fresh and say, let's look at some new classifications. We're going to stay with that, but we're going to use imaging to help us understand a few things. What is the best imaging that one needs to diagnose one of these posterior uveitis? What if I have a patient come into my clinic and I have a clinical suspicion, which imaging will really help me get that diagnosis? Now I'm following this patient in time. What is the best imaging I should use for this patient that will help me monitor this patient? So how will I know that, oh, this is a relapse now without waiting for, because yes, you know, posterior uveitis, patients don't complain. You know, the anterior uveitis, they have a red eye, they're symptomatic. With posterior uveitis, there could be active lesions that are not identified, and many times they see us and we are the ones who say, wait, this is active. We need to change your treatment plan because this is not working. And so that, and then the complications. Whenever there's posterior uveitis, you can have complications, most commonly cystoid macular edema, CNV. How do we monitor for this? Most of us will use an OCT, but is that the best? Is there something else that we could use? And this is what we did in our study. We tried to build upon these three. So we set up 5 committees led by Dr. Gupta, Vishali Gupta, and Janet Davis. And then we selected 5 people who would lead on these 5 disease entities. We chose these because they were most commonly referred to as a basket of white dots. You know, anybody who has AMPI is called white dots. But we know that maybe with imaging, we might be able to separate out these white dots and not put them in one basket, but have a very clear diagnosis and a much better definition for each one of them. So I was leading the multifocal choroiditis group, so I'll talk a little bit more about that one. So as I mentioned before, I'm not going to belabor the fact. With SUN, we used that as the foundation blocks. We did not change that. Everybody had to have no infectious disease. That had to be ruled out. You had to have a clinical appearance that matched SUN for a multifocal choroiditis. So that was a non-negotiable. And then what we did was we collected together a committee of people, because this shouldn't be my opinion or your opinion. We have to have a consensus where the uveitis community, the retina community, can come together and agree with something. So we very selectively chose people. We were like, let's take medical retina people. Let's take surgical retina people because they see these patients. Let's take uveitis because we treat these patients. Let's take imaging experts because imaging is evolving. We need to understand what's happening. They may have a better understanding of it. We took methodology experts, and then we made all these people into groups. Then we had actually the most time-consuming task was finding the cases, because even in my clinic, I might see a birdshot patient, but I may not get an FA at that visit. I may get an ICG one time, I get an FA to make life easy. So we had to find patients who had the entire spectrum. They have to have sun qualified diagnosis, and then they had to have color photos, and they had to have autofluorescence, and OCT, ICG, OCTA. So we wanted to collect all of that. So we searched, and we did not focus on numbers. We didn't want large data set, but we wanted perfect data set. So we then cleaned up these data sets, chose the ideal ones, decided that now we have a good set, and then we had multiple rounds of review where we looked at them and say, does this look like multifocal to you? What do you think? What do you think? Then we kept closing in until we found a group of set of images that we all agreed this was multifocal or this was PIC. Then we started to refine it further. What characteristics on the color photo looks like MFC? What characteristics on the OCT look like it? How do you know this is active? How do you know this is inactive? Let's try to work through it. And so we went to rounds and rounds and rounds. Then we had voting in that group. And then we decided, okay, this we agree, and I'll show you the images as we go. I'm just covering the methodology here. And then remember I told you we have 5 committees. So once we made our decision in our group, then we took this and we went to the full group, all 5 committees, which each had 8 to 10 people in it. And we said, okay, now here's what we recommend. Do you agree? And then we took in all their recommendations, whether they agreed with our recommendations or not. And then last of all, we went to Inflammasio in Singapore, and then we actually polled a whole room of 200 people. Dr. Gupta is going to talk more about that section. I'll come back and talk about MFC. So here's a color photo. And we found that, especially with multifocal choroiditis, a clinical exam or a photo can really give you a good idea of what the diagnosis is. In that, yes, there's multiple foci of lesions, multifocal, right? And then we found out a little bit more definition. If the edges are very sharp, is there a pointer here? It's okay, no problem. If we find that you have like very sharp round edges where you can see the end of it, that looks inactive. If the edges are a little fuzzy, that's suspicious for an active lesion. And as we go, I'll keep showing you more images. This is a PIC. Now again, remember Dr. Thorne said, small lesions more in the posterior pole. Thank you for the pointer. And you can see here, small lesions, inactive in the posterior pole. I showed you a wide angle optos, so you can actually see that there's no other lesions anywhere else, but you can have it. But they're small, discrete, and pigmented, inactive lesions. If they're active, they're a little bit more fluffy, they're a little bit more creamy yellow in color. There were some other things in literature that people have reported, but we didn't find it consistent. It's called Schlagel's lines, peripapillary atrophy, and we also find that, most of these patients are myopes, and myopes may have those findings in general, and so we decided it was not specific enough for multifocal or PIC, so we did not include that. And we've all looked at this when we were young. I still look at it, like how do you find 10 differences between the 2 pictures? So we try to do that, like is there a difference in multifocal choroiditis and PIC? Is it just lesion size? Is it location? Is it behavior? And what we found was that phenotypically they are different. As I said, big lesions, maybe small lesions, periphery, maybe more focal, but most importantly, when you're actually looking at how do they behave when there is activity, it was exactly the same. So an active lesion on PIC versus an active lesion on multifocal was so similar that the rest of the imaging that we looked at, we almost group them as the same. So when I'm showing you images, some may be PIC, some may be multifocal. I have obviously selected the better looking photos to show you, and so because I want it to be very classic. So on OCT, here's an example of an OCT image that shows an active lesion. And you can see on the SLO image, you can see all these lesions, and there are these like little spots here, and then down here you can make out this one is probably more inactive, this one probably looks a little bit more active, but the OCT shows you for sure that when it's active, there's that fuzzy subretinal hyporefractive membrane, like a little puff. We don't have a good word for it, where that may be the next step. Well, like how do we define this in medicine? We always choose food to define things, so maybe we'll come up with something, but as of now, we're calling it fluffy subretinal, and you can see how clearly that is not the same as the rest of the ellipsoid zone, and there's a big break in the ellipsoid zone. So that's why our patients are they notice it. They notice that there's something missing. There's a scotoma. They notice it. And when we look in them clinically, it looks like small lesions, but the impact area is probably bigger. And here's another set. You can see active images on the top, and in the bottom is inactive images. Same here, active, you see that fluffy membrane on the top, and in the bottom, there's that either that ellipsoid zone is thinned out or it becomes into a little scar. The ellipsoid zone may or may not fix itself. Sometimes the ellipsoid zone regenerates, sometimes it doesn't. And I've also mentioned here, there is focal choroidal thickening. These are myopes. You can see how thin the choroid is even in the inactive images in the bottom. But on the top images, you can see that there is a focal thickening of the choroid right under the lesion. And that's a very good sign. I've actually, now that I know this and I'm seeing it in my patients, sometimes you'll see the choroidal thickening even before the lesion becomes so apparent. So for my patients with multifocal and PIC, I am now getting more of the EDI OCTs because I'm monitoring them more using that. And here I just want to show some more examples of the ellipsoid zones reconstituting. What about autofluorescence? We always talk about autofluorescence being such a good tool for measuring choroidal lesions. And this side image was a patient of mine who I had seen just a few months ago. I got photos, and you can see these lesions up here. You can see how they're dark spots because those are inactive lesions. So when there is loss of the RPE, you see a hypo autofluorescence. That means that it is inactive, dead tissue, so to speak. And so this is a completely inactive eye. And then the patient presented back, and you can see in that same area with the red arrows, there are white dots there now. And the important part about that is because when there's inflammation, these photoreceptors, the RPE is getting triggered, lipofuscin is liberating. And so it's like a small box, the RPE. And when it's irritated and inflamed, it pops open and lipofuscin escapes. And when that escapes, you see all this hyper autofluorescence, and you can see it up in that area there lighting up. But I do want to make a point here. If I had only got OCT on this patient, I would have seen nothing because there was nothing at the macula. So this was helpful for a monitoring tool based on where the lesions are. Second point I want to make, even here, this picture is showing much better than this picture that I am looking at. So be very mindful about your screen that you're looking at. There might be imaging artifacts that may block things. Color contrast of the photo may be off. So some of the things I want you to be a little mindful of. And so clinical correlation is required whenever you interpret these images. But autofluorescence, ultra wide, especially if your lesions are peripheral, is really very beneficial. Can I keep going? I won't take longer.
Of course, please do.
Thank you. And this is another one point I want to make about fundus autofluorescence. Sometimes when you see the lesions, they may have a ring of hyper autofluorescence around them. This is not activity. This is just that lipofuscin pushed aside, and it can remain permanently there. So activity is diffuse lesion of hyper autofluorescence. Ring of hyper autofluorescence with hypo autofluorescent in the center is still inactive lesions. So keep that in mind when you're monitoring the patients. Fluorescein angiogram, wonderful tool. We use it a lot in retina and uveitis, but for multifocal lesions, you may see disc leakage if there's inflammation. You may see leakage from the lesions, but we did not think it, and of course CNV, but we did not think it added very much more in the monitoring or the diagnosis of multifocal choroiditis, because if the lesions are hot, you can see that on the OCT also if it's in these tractable areas. Same with ICGA. I don't know why the pictures are not showing, but same with ICGA, we did not feel, you can see new lesions that come up that can show you, I'm so sorry, I don't know why it's not showing, but you'll see more lesions in ICG, and they become, just that can show you as a good monitoring tool if your FAF, your fundus autofluorescence, or your OCT does not show it to you.
We all know that
also not showing, OCTA is a non-invasive, really helpful for monitoring for CNV. But not, nothing is there a problem with my slides loading?
Your chamber and vitreous A's.
Okay, so we make those recommendations that OCT is really helpful. Color photographs can be used as clinical exams, so not very much useful. Fundus autofluorescence, very, very beneficial. And then when we sent it to the entire group and we asked them to vote, you can see here that OCT and autofluorescence got the highest level of consensus, that that's what you would use, but all the other things got lower consensus, pretty much similar to what we had said. And so we're scientists. We never stop learning. We never stop asking questions. We never stop moving on. So what do we need? Even if one lesion is active, that eye is active. So how much are we going to track each and every lesion? And Dr. Vishali asked this really nice question. What is minimal residual disease? What is that threshold? When should we act? It's like when we see patients with anterior uveitis. If you see 1 or 2 cells, should you treat? Can you wait? Can you just watch the patient? And then imaging technology, every day it's evolving. You walk through the show floors and you get a headache because you're like, I just bought that OCT. Do I have to buy another OCT? And so, we are also learning. Imaging is learning. Things are evolving. Whatever we say today in 10 years is obsolete because something else has happened. The new kid on the block is more valuable. So for now, we're presenting these, and we hope that everyone can use this as a guide to diagnose and monitor and look for complications in MFCPU and PEC. Thank you. Feel free to email me if you have any questions. I'm always happy to talk. I'm especially happy to answer questions on this topic. Thank you.